damaged permanently by significant trauma. So this is a case that we had where you can actually see a fracture on the scan running through part of the cochlea. This child ended up going on to cochlear implantation. And so we have an intraoperative picture showing this fracture line here, very close to the round window membrane where we intend to place the implant. So the last thing I wanted to highlight that we might see on imaging is a constellation of findings that might make us suspicious for a congenital viral infection, specifically cytomegalovirus or CMV. So we can see these cysts in the temporal lobe. We can see these spotty white matter changes on an MRI that might clue us in to a congenital viral infection like CMV. CMV is quite common with a prevalence estimated at 0.5%. It's transmitted via contact with bodily fluid, and so that's urine, saliva. 10 to 15% of babies who have been infected with CMV in the womb will be symptomatic. And so when they're born, they have issues that are visibly apparent. They're almost uniformly in the neonatal intensive care unit or NICU, and have pretty typical features that will lead to a diagnosis early in life. And half of those children will have or develop sensorineural hearing loss. But that's a small proportion of all those babies infected with CMV. And in fact, 90% are asymptomatic. And so they look like normal, healthy, well babies, but 20% of them may still have or develop sensorineural hearing loss. And so the details of this study don't matter, but the point that's highlighted here, and this is a systematic review looking at large data across a number of studies, but the majority of losses in the symptomatic children, so the babies that are diagnosed pretty quickly and end up in the NICUs, are bilateral, whereas the majority of hearing loss in children who are otherwise asymptomatic are unilateral. And so this is another big subset of our population of children with single-sided deafness. And again, like the EVA, where there's forever a risk to the good or normal ear, 50% of cases with unilateral loss caused by congenital CMV will develop bilateral hearing loss by the age of 18. And so this is a really key point to make when we're counseling families about how aggressive to be when we're considering different treatment options. So diagnosing CMV is challenging for some reasons I'll get into here. You have to confirm congenital infection with a test done within the first 3 weeks of life. Okay, and the reason is CMV is so common that if you test a child a few months after birth, they could very easily have been exposed outside of the womb, in which case the virus would not cause the problems that we worry about. So it's only congenital infection in utero that will lead to things such as hearing loss. So it's easy for clinicians to suspect CMV in these symptomatic cases. Babies have classic features, and so testing happens within that timeline. But what about these otherwise asymptomatic babies? Babies who look normal, who are healthy, but might have hearing loss. One way to potentially capture them is through hearing targeted screening. So if a child fails their newborn hearing screen and a subsequent follow-up, then it triggers reflex testing for CMV. So there is lots of variability across states in our country. It's now happening in Pennsylvania, but not happening in Delaware, for example. The ideal way to pick them up would be through universal screening. So we screen universally for lots of metabolic disorders that are pretty rare in children. We do obviously now screen all babies for hearing loss. And so there's an effort to consider universal screening for CMV as well. It's only happening currently in one state, and it just started last week. That's the state of Minnesota. Now, people on this Zoom today may be familiar with sort of the origins of newborn hearing screening and how sort of difficult that path was. I mean, you have to generate a very strong case for sort of a cost benefit at the national level to make this acceptable. When it comes to pushing states and the federal government to implement something like this. And so this process is ongoing. It's been an evolution for a number of years now. We're seeing things move at different rates across states, but just know that, we in Delaware and through Nemours are advocating to implement more testing capabilities in the children that we care for. And there's a group that's been meeting monthly. We had a meeting earlier today that is trying to sort of push all of this forward for the state of Delaware. So one thing that we could consider when we meet a child who is older than 3 weeks of age is to try to retrieve their newborn dried blood spot to test for viral DNA. So I mentioned that all babies are screened for these rare metabolic disorders. They do it with a heel stick. They take blood and it becomes this dried blood spot, and it can be tested for various things, and it's saved. It was historically saved sort of indefinitely, but now states are moving to get rid of these blood spots. Some reasons related to privacy concerns, a lot related to cost. But again, like with sort of the approach to screening for CMV, this is managed quite differently across states. So in the state of Delaware, the dried blood spot is being destroyed 3 months after birth. It's 1 year in PA, and it's over 20 years in New Jersey. So, for us to have the option to pull this blood spot and test it, we only have a 3-month window in Delaware, which is really tight and often missed by the time a baby gets to us after diagnostic testing for consideration of this. But in PA, you have some more flexibility. You have up until age 1. And so most of those kids will have gotten in to see audiology for diagnostic testing, will have seen us in otolaryngology for workup. And so it becomes more feasible to consider pulling the dried blood spot and testing it. So we have protocols in place for testing the dried blood spot in all the states that we see kids. So not just Delaware, but Jersey, Pennsylvania as well. And we've tested children from Maryland too. And so the contacts in the states are different. It's pretty complicated. It's ever evolving. It's not perfect. And even when we get the test, it's still not perfect because it's poorly sensitive. And what that means is that a negative is not definitively a negative. But on the flip, it's very specific. And so if we do the test and it comes back positive, we can feel confident that it was truly a congenital CMV infection, and that helps frame our counseling. So in cases where imaging is negative and we either can't do the CMV testing or the CMV testing is negative, the last thing we would consider in working up single-sided deafness would be hearing targeted genetic testing. Most genetic causes will affect both ears, but not all. Wardenburg in particular, we've seen a couple of cases of single-sided deafness. And so the protocol here has become more streamlined for families. It's often just a telehealth visit to start. Even prior to the visit, the genetic counselors have run the family's insurance to make sure that there won't be any out-of-pocket costs of the testing they might suggest. They can send a cheek swab to the family's home, and then they mail it in to the center where the tests are done. And we usually get results within 2 months. So imaging, CMV testing if possible, and then hearing targeted genetic testing. These are sort of the 3 arms that we use to look into the why of single-sided deafness. So whether or not we figure out why a child is deaf in one ear, we do know that there's a functional cost. So when you're deaf in one ear, you have to deal with the head shadow effect over time. This isn't something that a young child is going to complain about, but it's certainly very bothersome to older children and adults with single-sided deafness. So if I'm deaf in my right ear and I'm driving a car and people are talking to me on my deaf side, my head is in the way from sounds getting to my only hearing left ear. And that's bothersome. I mean, in most listening situations, children or adults will learn to turn their good ear preferentially to the sound source. But like when you're driving, I mean, you got to keep your eyes on the road. And so your head is kind of stuck in the way when the passenger next to you is trying to talk. And so it's a source of frustration for sure. We also know that there is significantly increased difficulty listening in noisier environments. So if you test a child with single-sided deafness in a booth, it can do pretty well. But the real world is not a quiet sound booth. And so there's lots of noise. And when you only have one ear to listen, it's quite difficult to listen to noise. And the reason is you're losing some advantages of the binaural system. So binaural is listening with two ears. And so when we're listening with two ears, there are mechanisms to filter out background noise and focus on the source that we're interested in. And that's the two ears kind of working together, figuring out differences in timing and loudness between the ears. You lose that when you're deaf on one side. And so it makes things very difficult in noisy environments. This is that cocktail party effect. With normal hearing, though it's a little bit harder, you can focus on a conversation at a loud cocktail party, but when you are deaf in one ear, it's near impossible. It's also impossible to localize sounds. So sound localization is also dependent on figuring out the difference in timing and loudness between the ears to know where we're being called from, if it's in another room or out of sight behind us. And so all of this matters. Unfortunately, the functional cost was historically dismissed because speech and language development in these cases is expected to be mostly normal. So if you're deaf in one ear, we don't predict significant language delays that will become prolonged or trouble with articulation per se. We do actually predict normal speech and language development. But there are longer term consequences of this increased listening effort that are now apparent. I mean, in young children with emerging language, grade school age children, they're not necessarily going to complain about this head shadow effect. It's not going to be so obvious that they're struggling in noise. Their inability to localize sound will be apparent, but that's something that you can usually work through. But over time, so as grade schoolers move into middle school and then high school, we start to see problems kind of boiling over. And so we now know that there's impaired social and emotional growth related to this increased listening effort. School performance can be affected. Again, it's subconscious, but the brain is consuming more resources to simply listen. And so that detracts from memory and learning. Again, with the subconscious increased effort of listening, you can feel tired and you can even have headaches at the end of the day. And so these symptoms we're hearing more from older children who have been dealing with it over a longer period of time and are now in more complicated listening environments further along in school. And so there are also changes happening in the brain developmentally related to loss of input from one ear in cases of single-sided deafness. So this is normal anatomy. So if you're listening through the right ear, you're going to get activation on both sides of the brain. So both temporal lobes, where the auditory cortices or hearing parts of the brain are, will be stimulated by sounds coming to one ear. There's actually a contralateral preference. So sounds coming to the right ear are represented more strongly in the left hemisphere and vice versa. So sounds coming to the left ear would be more strongly represented on the right. That's the normal setup. So you've got input going to both sides with a contralateral preference. And there are neuroimaging studies that can demonstrate this beautifully. So this is very well understood at this point. But after prolonged auditory deprivation, so greater than 2 years of not hearing well or not hearing at all in one ear, that contralateral cortical preference is reversed. It goes away. So the better hearing ear is stronger and more extensively represented in the auditory system. So if you're deaf in the left ear and the right ear is stimulated, you're going to see this activation on both sides that will look pretty symmetric. You're going to lose that preference to the contralateral side. This may at a certain point become irreversible, and when that happens, the likelihood that any treatment will help wanes, right? So if you allow the brain to rewire in this way, and then many years later decide to intervene, say for example with a cochlear implant, if those pathways have changed and are simply not as strong as they once were or once could have been, the outcome is likely going to be poorer. And so this is something that we have to keep in mind when we're considering treatment options. So what are the treatment options? Traditionally, for school-age children, we'd make sure that they had individualized education plans, preferential seating in the classroom. We could advocate for use of a personal FM system. Teacher has a microphone and it's coming right to a speaker next to the child, or they could wear a device so it's coming right to their good ear. And this is in an effort to ease their listening effort. So improving the signal to noise ratio, bringing the teacher's voice directly to the child's good ear so that that is dominant over the background noise. And then you could consider bone conduction aids or implants and cross aids to help with the head shadow. So I've yet to have a child with single-sided deafness or a family of a child with single-sided deafness opt into an implantable bone conduction aid simply to get around the head shadow effect. But lots of adults over the years have opted for these. And so coming back to the example, if I'm deaf in the right ear, I could get a bone conduction implant. Microphone on that side will pick up sounds coming to the right, vibrate through the skull to get the information to the left ear. But this does not help the Baha or the cross does not help the poor hearing ear actually listen. It doesn't help with listening to noise. It doesn't help with sound localization. These technologies simply help to mitigate the head shadow effect. And so more recently, cochlear implantation has become a consideration in these cases. So it was just FDA approved for use in single-sided deafness in 2019. So right before COVID hit. And the FDA states that it's approved for use in children greater than age 5 with single-sided deafness and less than 10 years of profound deafness. Now, there are a couple of things that don't really sit right with us about this FDA indication. The first is age greater than 5. A lot of the children who we think might benefit most come in younger than 5, right? So if they have congenital CMV infection, or maybe they've been diagnosed with bilateral enlarged vestibular aqueducts, if we've got one deaf ear and one good ear, in those cases where we know there's a risk of developing hearing loss later in life in the good ear, we want to do something as soon as we possibly can to restore some redundancy in the auditory system and prevent the development of that aural preference syndrome. So, if we're waiting for kids to be 5 and if we're allowing them to go up to 10 years of time with auditory deprivation, the science is telling us that we've already created an aural preference syndrome, and that any intervention at that point is less likely to have a maximal benefit. And so we've actually done more of these implants off-label, backed by the proper science. And so the cases that I just cited as examples are those that we feel strongest about: prelingual single-sided deafness. So prior to language development, we worry about the potential for the aural preference syndrome. We want to prevent that from happening, especially so if there's an identifiable risk of future hearing loss in the normal ear. And the cases that I keep coming back to are EVA and CMV. So cochlear implants have multiple components to them, right? So there's the implant that we place surgically, the electrode that goes into the cochlea here that takes advantage of the tonotopic organization of the cochlea to provide frequency-specific stimulation that can be put back together in the brain to understand speech. There's an external sound processor with a microphone, and then this coil or transmitter is sending the external information to the internal device to stimulate the cochlea properly. What are we hoping for when we recommend cochlear implantation? We want to create some auditory redundancy. So if you only have one hearing ear and something happens to that ear, it can be a crisis. And so we want to have some backup in place. We want to eliminate the head shadow effect if we can. We want to ease the effort of listening to noise. And so we can do that when children learn to listen with the technology. It's not just now overcoming the head shadow, it's also helping them to listen more effectively in noise with less effort. And we can, to some degree, improve the ability to localize sounds, but this is certainly imperfect, and for reasons that make sense. I mean, the speed at which sound is transmitted electrically up to the hearing brain is faster than that which normal acoustic stimulation will be perceived in the brain. And so the timing cues that we're kind of figuring out, or the timing differences between the ears, is always going to be a bit harder to interpret when one side is listening through electrical stimulation, the other is listening through natural acoustic stimulation. So children who are implanted for single-sided deafness can localize a bit better, but still not perfectly. And so what do things look like post-op? We have to provide pretty extensive counseling. I mean, we're not going to turn the device on until about 2 weeks to allow swelling and discomfort to subside. They're going to have regular mapping visits with audiology quite frequently at first, and eventually every 6 months to kind of tweak the input through the device. And then intensive audio verbal therapy, which is really listening therapy versus traditional speech therapy, starting 1 to 2 times a week for the first several months. It's challenging when you can hear just fine with the other ear. And so there are different techniques like plugging the good ear to get children to really try to lean on the input they're getting through their implant, especially early in the experience. And consistent wear time is the key. We can't counsel enough that if a child is not trying to commit to the device, it's really never going to have the same impact that it might. So what have we learned in this early experience dating back a few years now? Data logs, where you interrogate the device and get some information about the average wear time per day and what the listening environments look like, has been pretty consistent over time for most. And so this is a good measure of acceptance. It seems that most patients, children, are keeping their devices on, and it helps us feel comfortable that the use is not negatively impacting what they're getting through their normal hearing ear. Now, different outcome measures that we might look at, such as speech perception, listening to noise, sound localization, do all generally improve, but the improvement can be variable. I did specifically cite that localization tends to still be difficult. And science is starting to tell us that the benefits may be greater in children with early onset of single-sided deafness versus later onset of single-sided deafness. And this probably relates to the neuroplasticity of the rapidly developing brain early in life. It's just more capable of adapting to this new stimulation and learning to use it in an organized way. So finally, some pictures looking at this cortical organization. Again, the details of the study are not so important, but the pictures tell the story. So we're kind of looking down at the top of the head. So this would be the left side, and this would be the right side. And so these are cases of single-sided deafness, all left-sided. And so shortly after implantation, when you stimulate the left-sided implant, you see a whole ton of activity on the same side in the hearing brain. And you see some activity on the other side. Okay. When you present an acoustic stimulus to the normal hearing right ear, you see the typical preferential excitement on the contralateral left side. But over time and experience with the implant, this sort of disorganized activity that's mostly ipsilateral or same side to the implant on the left moves to the contralateral side. And so this contralateral cortical preference is restored with consistent use over time in children who are implanted in a timely fashion. So again, now this actually looks normal. So the implant on the left, when it's stimulated, there's preferential activation on the right side of the brain. And then when they listen normally with their right ear, there's preferential activation on the left side of their brain. And so early developmental changes that are occurring can be fixed with timely implantation and consistent use in the right candidates. It's pretty cool. So wrapping up, just a few conclusions. We've gone through some of the common causes of SSD, including anatomic abnormalities like cochlear nerve deficiency and enlarged vestibular aqueducts and congenital CMV. And so anatomic abnormalities and CMV together probably account for upwards of 90% of cases of single-sided deafness. The functional cost is significant, and it's more obvious over time. So again, the older kids, middle school, high school, when we ask the right questions, the symptoms are almost universally present to some degree. Treatment options have thankfully expanded and now include cochlear implantation, but it's really important to be careful about selection. So it's not simply looking at this FDA approval and, are they over 5 and have they been deaf for less than 10 years? Yes, great, we're a go. It's far more complicated than that. In fact, we're more often implanting off-label in young children who have a risk of developing hearing loss in their good ear because we want to restore redundancy. We want to promote normal auditory brain development and prevent a future crisis of being dependent on one ear and having that hearing cut out all of a sudden after having developed oral language without any tools to use as a backup. And so if we restore that redundancy early in life, then a child can always lean on their implant, ideally, if their hearing were to change in their good ear. And so that's kind of where we are with things right now. That's everything that I had prepared for today. And I think we do have plenty of time for questions should anyone have them. So thank you again for the opportunity, and I'm happy to answer any questions.
Thank you, Dr. Parks. That was great. Yeah, so you can feel free to unmute yourself to ask a question, or you can type it into the chat to read it off. And I was actually gonna ask a question. Have you seen in any children that have gotten the cochlear implant then preferring that side over their normal hearing ear? Has that ever, I don't know, been a case or a child that you've seen?
No, I've not seen that, but I mean, that was at least one of the scientific concerns or questions sort of before the FDA approval and before people really started offering this clinically was, that last slide before the conclusions where I showed sort of the pictures of the brain and that contralateral preference being restored. I mean, there was concern that maybe, both sides of the brain would be activating preferentially to the implant relative to the normal hearing ear. Thankfully, that's not been demonstrated, but that would be a concern.
Right. Okay. Understood. Angie, I don't know, Dr. Parks, if you could see her question.
I can. Yeah.
Okay.
Yeah. No. So it's on the insurance side. So all cochlear implants require prior authorization. So we never move forward without authorization from the companies. When the FDA approval hit, we knew that we'd have cases that wouldn't fit their criteria cleanly. And so we've generated some letters that are sort of templated for single-sided deafness in particular. And then we will kind of put in the specifics for the child relative to their diagnosis. And we have yet to have a case that did not get authorized based on our letter. So, I mean, the FDA provides guidelines, but that's not like a hard stop per se. It's just sort of a limitation of what they've reviewed thus far. And when we are citing the proper literature and explaining our case as to why it's scientifically sound and in the child's best interest, we're getting authorization. Sometimes it requires what's called a peer-to-peer review, where initially it's flagged and then we have to speak to a clinician on the side of the insurance company. But like I said, we've yet to want to do one that we could not do because of insurance.
Now I know children who get cochlear implants, generally who have them bilaterally implanted, by age 2, they say that it's kind of late in terms of getting children implanted. So it seems odd that you would, even though you do have normal hearing on one side, that they're recommending this rule of age 5 or greater.
Yeah, I mean, it was the data is pretty limited, and it was kind of pulling adult data and much smaller sample size of the pediatric data when the FDA approval hit, because that's not, the indication was also for adults too. So they kind of put that piece in about kids. But yeah, you're spot on that it really doesn't make much sense from a neurodevelopmental perspective. I mean, accepting cases of delayed onset loss, acquired loss. You have normal hearing in both ears, and then at 10 years old, you have temporal bone trauma and go deaf in one ear. Well, that's different. And sure,
Right.
They haven't been deaf that long. They had strong development of auditory pathways earlier in life, and so we still think it would work. But yeah, to wait arbitrarily until the age of 5 if the child is prelingually deaf is really nonsensical, and so that's why we've felt comfortable as a program. And I think most academic programs around the country and the world are saying the same thing in advocating for implantation in those cases. And it's especially so when there's an identifiable risk to the good ear. That's where we feel strongest. Now, there are other cases where kids are deaf in one ear and we can't figure out why. The imaging is normal, the CMV testing is negative or it's not possible, and genetic testing is inconclusive. And then you start to feel kind of stuck. And it's hard to take we do not take a firm stance that, we should be implanting this ear. There are advantages to listening with 2 ears. It's a more difficult conversation. I think that for us as clinicians and for parents, it just makes a whole lot more sense. It's easier to wrap your mind around, like, okay, we've got a good ear right now, but we don't know how long it's going to be a good ear. Is this a forever thing? Is it not? And when you have that worry, it's an easier decision to say, let's do everything we can for the bad ear and implant early. But if we don't have that identifiable cause, there are certain instances for sure where families just choose to observe, and we can't really take a firm stance that it's the wrong thing. We acknowledge that there are predictable difficulties that are going to arise, and that as more time goes on, if people change their minds, the benefit of an implant is probably less over time, but it's not clear what's right and wrong in those situations.
Right. Yeah, that makes it hard. Absolutely. Fiona?
Hi, yes, good morning. Well, good afternoon, I guess now. You mentioned amplification for single-sidedness. Now, can you expand on that more? I was a little confused with, because you mentioned the Baha, but then I couldn't remember what you said about what is actually recommended for that, if any.
Yeah, and this talk was kind of, we defined single-sided deafness the way it's defined in the literature. So it's severe to profound loss that's not aidable. So we're not talking about unilateral hearing loss, all comers, where you might have an aidable, mild, moderate, moderately severe, even severe loss. These are children who would not have any aided benefit, very poor or no speech discrimination. And so the point I was making about a Baha or a cross aid is that you are not amplifying the bad ear in a helpful way. You're simply getting around the head shadow effect. You're getting sounds coming to the bad side and bringing them over to the good side. That's all that those technologies would do. In these cases of severe to profound loss, it's not aidable.
Okay, great. Thank you.
Yep.
Is there any other questions or comments?
And Ariel, I will say, kind of coming back to your question, I mean, we can predict what that outcomes may be poor, but it's not a certainty, right? And so we've, especially when the FDA approval hit, there was sort of a lot of buzz about this, and a lot of families coming in with much older children interested. Hey, we're over 5 and been deaf for 8 years, 9 years. It seems to fit the criteria, and some of those cases are challenging too. I think it's 10 years of auditory deprivation. It was a prelingual loss. We feel pretty firm in saying we don't think this is going to be helpful. It's not worth putting your child through. We could restore the ability to hear something, but we would have no reason to believe that that's a meaningful something that they're going to enjoy and commit to. But there is a gray area, right, where a child might pass their newborn hearing screen and then show up at age 5 after failing a hearing screen through school for the first time. And my first thought is, they probably have cochlear nerve deficiency. Let's get an MRI and see. Oh, okay, no, they have a cochlear nerve. The anatomy is normal. Can we test for CMV? State of Delaware? No, we can't do that anymore. They're 5 years old. All right, well, let's look at genetic testing. The yield is low for unilateral loss, so that comes back normal. Okay, well, how long have they been deaf? Well, they passed their hearing screen. They're now 5. They're completely deaf. We predict normal speech and language development with single-sided deafness even early in life. So could they have gone deaf within the first few months? It's possible. Could it have happened more recently? A child at that age is not a reliable reporter. So you just don't know. So when 5, 6, 7-year-olds come in, they pass their newborn screening. We have no data in between. This is a struggle.
Yeah.
Who are we to deprive of potential opportunity? But we do have to counsel extensively that we're accepting a lot of unknown together. And so you can imagine that a lot of parents struggle with that. We struggle with them. And we've had cases go in both directions, where acknowledging the uncertainty and the risk of becoming a non-user, families proceed. And we've had a case or two where children, are not really enjoying their implant. And, we pretty much predicted as much, but just couldn't predict it with 100% certainty. And so all agreed together to move forward. But there are other cases where families just decide, the uncertainty is just too much and we're not going to do it. And we support that too. So it's tricky.
Right. And have you ever had any school reporters that noticed something that the child's behavior was off or learning was off that recommended that could potentially be that, it's the hearing, in the one-sided hearing loss?
You're saying like as a means to arrive at the diagnosis, like nobody's known about the hearing loss until
I wonder, because
if
it's a hard diagnosis for children to report, I wonder if, they're the effects of school, of what's happening or going on in school, is an indicator at all.
I think that it's happened anecdotally. I mean, where a child has come in because concerns were raised about some listening difficulties, and they're diagnosed with, it could be bilateral hearing loss, but certainly unilateral too, of various degrees, not necessarily single-sided deafness. But what's really helpful is the routine screening that's done at that point. And so through the well visits, usually starting around age 4 or 5, and then in the schools around a similar age, and annually we're getting hearing screening done that's going to pick up most of these cases. So I'd say the vast majority are picked up through screening when they had been asymptomatic up to that point, as opposed to people noticing a problem. Because I think that a lot of the problems that relate to the single-sided deafness are just pretty invisible for several years.
Yeah, that's what I was wondering, if that's why I was asking about school being an indicator, because that can be really hard if you don't have the child telling you, I don't hear. It's got to be incredibly hard.
Right. Like I can think of a case or two where, I'm wearing AirPods now. So it's come to light because a parent is sharing AirPods or headphones with a child, and the child just innocently says, "That's my bad ear. Can you put it in my good ear?" And they say, what do you mean you have a good ear and a bad ear? And then they get tested, and sure enough, they're deaf in an ear. And how long have they been deaf in the ear? So sometimes it comes up that way too.
That's really interesting.
Yeah.
Wow. Yeah, that makes sense.
Hi. So I just thought I would chime in on this. In our situation, my grandson is 14 years old now. And the way that we discovered that he was having hearing loss, he was a great, great faker. He could get through any hearing test at school, and he was great at faking it. I was actually talking to him one time on summer vacation, and he did what I called a Stevie Wonder. All of a sudden, he starts swooming his head around. Bingo. That was our defining moment to go up to Nemours and get tested.
Yeah.
And so it was just something as simple as him doing a swivel with his head.
Yep.
So it can come across that way too. And I just thought that was valuable to share. So there.
Sure.
Yeah, absolutely. Thank you. I appreciate it. All right. Well, if anyone else, if no one else has any questions,
Hey, it's Tracy. I've just kind of been sitting on this one because recently something came across the EAA, the Educational Audiology Listserv, of an audiologist who has a deaf daughter, and her anatomy was kind of, I think, confusing at first. And, she'd seen a lot of specialists. They were doing a lot of imaging. They came to the conclusion she's got bilateral hypoplastic nerves. And they actually ended up going with implants, and she did the Med-L because they had like the triphasic something that actually I had not heard of before. So she was explaining in depth what that meant. So it made me think of, what is your clinical decision making when it comes to anatomy? Are you looking at like, it's one or the other? Either you have complete anatomy and you're moving forward, or do you find that there's some sort of gray area, like maybe if this looks this way, we can try it, or any experience with that?
There is a spectrum, especially with cochlear nerve deficiency, where you can have a visible nerve present, but it might be smaller. I think that in a unilateral case, you'd be far less inclined to entertain an implant with a significantly hypoplastic nerve, even if visible, very, very thin, with normal anatomy on the other side, no identifiable risk the other side. Sort of the likelihood of benefit with a hypoplastic nerve is probably outweighed by some of the risk and commitment you'd be accepting by embarking on that path. But if you had a bilateral case, it becomes trickier. Most cases that we've had like that would be in medically complex syndromic children, Charge, for example, where you have a whole lot of abnormal anatomy, subtle differences between the sides, limited oral language skills, limited ability to test behaviorally, oftentimes on the auditory neuropathy spectrum. So even interpreting electrophysiologic data is challenging. And so those cases can be trickier. And it's not a hard stop per se, but it's all about counseling to the best of our ability and setting realistic expectations. And I mean, there have been a couple of cases that we've not recommended moving forward on because of severely abnormal anatomy. We've directed some of those families to other institutions. NYU is sort of the big regional center where they have the capabilities to do auditory brainstem implants. So that's not something anyone in our region has expertise in, CHOP included. And so there've been a case or two that we've referred up to Tom Rowland's group at NYU with especially abnormal anatomy.
Actually, I have two of those kids that I feel like I have a lot of kids right now that have abnormal anatomy, and I'm working with two that have been referred to, Tom Rowland and his group at NYU. So I've kind of always been thinking about their anatomy, and they've got a lot of other stuff going on.
Yeah.
But I feel like I'm seeing more and more anatomical stuff pop up, auditory brainstem implants, and just kind of thinking about all those things. So very interesting.
They're the most extreme cases. I mean, there's a lot of abnormal anatomy that we safely implant and predict will have decent outcomes. The more abnormal the anatomy, the less able you are to predict the outcomes, but we can still safely move children through surgery. But there are some exceptions for sure, like very, very underdeveloped inner ears with mixing of fluids with the CSF space. Like, it's not just that the auditory outcome is very much in question, but also there's a substantially higher risk of significant complications related to surgery and afterwards, and meningitis, brain infections, and things like that. So it gets complicated, but it's never simply a, oh no go period because of the MRI findings. It's a lot more involved, I would say.
Right. Thank you, Dr. Parks and our interpreters. This is really great and informative, like everybody is saying. We really appreciate you being here and giving your time. So thank you so much.
Yeah, thanks for having me. I'm happy to do this again in the future for sure.
Awesome. Thank you.
All right. Have a great afternoon.
You too. Bye, everyone.
Right, see ya.
See ya.